It gives me great pleasure to welcome you to the dermatopathology section of 10th Emirates Pathology and Digital Pathology Utilitarian Conference. I'm going to be talking about low-grade sweat gland carcinomas in this presentation, and this is particularly directed towards the younger members of the audience. Before starting, I just want to acknowledge the kindness shown to me by members of the Facebook McKee group, the Keynote.com platform, and colleagues who have sent me cases in consultation. And below are a list of all of the doctors who have so kindly shared cases that I've included in the following presentation, and I really appreciate their help. Now, low-grade sweat gland carcinomas are tumors that commonly recur but rarely, possibly if ever, metastasize, with the exception of adenoid cystic carcinoma, which I think does have a significant metastatic potential. And this slide on the right, this image on the right, is from a microcystic adnexal carcinoma, and it has a beautiful keratocyst in the middle of the field. And this was very kindly shared with me by Professor Michael from Pilsen. Now, a microcystic adnexal carcinoma is a very rare tumor. As you can see in the top line, it has an incidence of 0.16 to 0.65 per 1 million of the population. But the funny thing is, on a personal basis, this is the tumor that I've mostly encountered, but obviously that reflects referrals rather than cases encountered in primary sign-out. It's a tumor which tends to affect the middle-aged and the elderly, although as you can see it's been described in a patient as young as 6 years. And it's very much a tumor of Caucasian skin. There are some cases in the literature, maybe a handful, of macurizing in patients with black skin, but in relative terms that's very rare. Now, the tumor, it may arise at all sorts of sites, but it does show a predilection for facial skin, particularly around the eyes, on the nose, and around the mouth. And most cases present as an area of induration. And one of the things you have to remember about this tumor is when you palpate it, let's say perhaps you feel an indurated lesion of about 1 centimeter in diameter, the chances are when you go to surgery, this lesion will measure, perhaps 2 centimeters or even 3. They are very, very deceptive lesions, which is one of the reasons why they're very difficult to treat. Sometimes patients present even before a clinical lesion is evident with pain or burning or tingling, and this is due to the presence of perineural infiltration. I'll talk about recurrence rate and metastasis a little later on in this talk. Now, these are some clinical photographs of MACs that I've encountered over the years. And on the top left, I don't know how good this arrow is, but hopefully you can see it. And I'm showing a small ulcerated lesion on the lower eyelid. And you can imagine that's going to be so difficult to treat clinically. On the bottom left, just at the upper part of the nose, you can see a yellow a yellow lesion with some surrounding erythema, and clinically that's a very small example, but when it was excised it involved much more skin than was apparent clinically. And this is the same patient, a different view that I showed earlier. And in this patient, this is recurrent disease involving most of the forehead, and all of the white areas that you can see here, those all are recurrent tumor. Now, when I was working in preparation for this talk, I came across some interesting clinical lesions, and in this slide we can see BCC clinically mimicking a basal cell carcinoma. And in this example, the patient presented with multiple nodules. There are at least 1, 2, 3, 4, 5 nodules in that field. There's another one there, although I don't know whether that was another focus of MAC or not. And then I came across this case, which I thought was really interesting. The arrow points to a clinically very small lesion affecting the upper eyelid, but the CT scan on the right shows the tumor has extended and occupies pretty much all of the the cavernous sinus. So this will emphasize to you how aggressive these tumors can be, and it makes it clear how difficult they can sometimes be to treat. Now, histologically, microcystic adnexal carcinoma is a zoned tumor. At the top of the tumor, you tend to see mostly keratocysts with lamellated keratin and including a granular cell layer. And as you work deeper into the tumor, dense fibrous tissue provides a very sclerotic stroma, and the keratocysts become replaced by narrow epithelial strands, showing ductal differentiation, although sometimes it's quite hard to find ducts. But if we look at there's the arrow there. I hope you can see this strand. There's a little area of ductal differentiation there. And tumors are typically very poorly circumscribed, so it's very hard to find an edge to the tumor. Now, it used to be taught that microcystic adnexal carcinoma was a tumor of the eccrine sweat duct, but then examples were published with Immunohistochemistry suggesting that perhaps the tumor is derived from the hair follicle, or possibly the tumor shows differentiation towards both follicular and sweat gland apparatus. Phil Lebois described 6 cases of MAC in which there was sebaceous differentiation, and I have an example of that I'll show you later. Sometimes tumors show clear cell change, and this is thought to reflect differentiation towards the outer root sheath of the follicle. Now, ductal differentiation is an invariable feature of this tumor, and you sometimes have to search quite hard, and it's why I always recommend EMER and CEA immunohistochemistry and diastase PAS for mucin secretion when one's looking at a challenging example. If any of those are positive, then you're home and dry, whereas if they're all negative, well, then you're probably looking at a desmoplastic trichoepithelioma. Now, for years, I've always taught people that if you see perineural infiltration, then this is inevitably means that the patient has a MAC. but there was a recent publication, I think it was in the American Journal of Dermatopathology, but I'm not sure about that. Anyway, six cases of pretty much textbook desmoplastic trichoepithelioma were presented showing perineural infiltration, and that came as a bit of a blow to me because it means that I can't use that as a diagnostic absolute criterion for MAC. And lastly, we sometimes may encounter the solid variant, and I'll show you an example of that later. So here are some fields, and again, this is the first case that I saw of MAC, and it belongs to that patient that I showed you with the tumor at the angle of the mouth. And in the top left, you can see lovely keratocysts and little small nodules of tumor cells and narrow epithelial strands, with a close-up of the keratocysts on the right. And in the bottom left corner, clear cell change is evident, and the keratinization looks a bit more pilar than epidermoid. And in the bottom right, you can see narrow epithelial strands. And what I want you to particularly pay attention to is the fact that there really is no significant pleomorphism in the epithelial component of a MAC. And that's very typical. And just in passing, mitoses are very rare in this tumor, so it's not worth your while looking for them. And in the upper fields, there's very nice ductal differentiation, and if you look closely, you can see the cuticle lining the ducts, and it's very nicely shown on the right-hand field, where you can see a cuticle lining that vacuole. So that's an intracytoplasmic lumen with the cytoplasm compressed to the edge. And in the bottom left-hand corner, you can see microcystic adnexal carcinoma extending down and involving skeletal muscle. And on the right, the epithelium is presenting as larger, rather nondescript nodules, and this is a field of the solid variant, which I'll get back to later. And further images are emphasizing the clear cell change, the keratinization, in this lower right-hand field, rather more pilar in type. And in the upper field, you can see both perineural infiltration, and also there's the nerve there, there's intraneural infiltration. And this accounts for the difficulty in excising these tumors. And sometimes MAC can grow along cranial nerves. And I think there's a report somewhere in the literature where the patient presented with carcinomatous meningitis following a MAC. Now, this is a lovely case that I wanted to share with you that Mara Rava presented on the Keynote.com platform, and it's a very beautiful example of microcystic adnexal carcinoma. Now, if you can see my arrow, then following down, you can notice the keratocysts on the right-hand side, and if we go to the middle of the lesion, there's some acanthotic epidermis, and then deep to that, there is a dense fibrous stroma with small epithelial strands. And the thing that struck me about this case, this is a scanning view, but even in the scanning view, you're able to see perineural infiltration. There's the arrow, so I'll travel it up, and there's a nerve ensheathed with tumor. And over here we have another nerve with perineural and intraneural spread. And those are nerves over there. And in fact, pretty much every nerve in this tumor, or surrounding this tumor rather, was infiltrated by microcystic adnexal carcinoma. And there's a close-up view showing you the keratocysts. And you might notice there's a multinucleate giant cell reaction in the bottom left quadrant, and this relates to rupture of a keratocyst giving rise to a foreign body giant cell reaction. And if we look towards the bottom of the field, there is a nerve ensheathed with tumor. There's another one ensheathed with tumor, and towards the middle of the field you can see intraneural spread, and on the right-hand side you can see some more nerve infiltration. There's a close-up view of the cysts, and there's a close-up view of the epithelial component. And again, I'd highlight to you, if you look at this closely, the nuclei are all very bland. They all look the same. There's nothing pleomorphic about it. And as I mentioned, that's typical of the tumor. And here's another view showing the ductal differentiation. And there's infiltration of skeletal muscle. And there's the nerve involvement. And this is a lovely case that Gerard Gardner shared with me. Now, most microcystic adnexal carcinomas show those two components, the keratocyst superficially and the narrow epithelial strand in the deep component. But sometimes tumors show little or no keratocyst formation, and they just have the deeper glandular component, and this is sometimes known as eccrine epithelioma, and this is an example of that. In this other piece of tissue from the same tumor, there was a little keratocyst at the top, shown in close-up there. But most of the tumor is composed of narrow strands of epithelium, and this is a beautiful example showing widespread intracytoplasmic lumen formation and ductal differentiation. And there's a view of the deep part of the tumor showing extensive involvement of skeletal muscle. And there's a beautiful field. Isn't that just so gorgeous? It's almost rather like a tadpole in a syringoma, I suppose. But again, the nuclei are all the same, and many cells contain intracytoplasmic lumina with the most beautiful cuticle outlining the spaces. It really doesn't get better than that. And there's the tumor extending into skeletal muscle, and there's the tumor showing intraneural spread. Whoops. And then lastly, sorry, my computer's got a mind of its own. I'm sorry about this. There. I apologize for that messing around, but computers, well, we love them and we've learned to hate them too sometimes. Now, this is my last microcystic adnexal carcinoma. It's an absolutely beautiful case, and this was shared with me by Matthias Bobos, who lives in Thessaloniki in Greece. And I just to cut a long story short, the patient presented with nevus sebaceous on the scalp, and this is a very deep biopsy along the bottom of the image. This is the gallia aponeurotica, and you can see the tumor is extended down into it. Now, the interesting thing about this image is that there are 3 tumors here. I hope you can see my arrow. I'll move it there. This bit here, this segment here, this is syringocystadenoma papilliferum, or SCAP. And then this bit here, which I'll show you in high power in a moment or two, this is squamous cell carcinoma. And then all of this, everywhere else, is microcystic adnexal carcinoma. And I'm going to put my arrow, it's pretty much in the center of the field, and perhaps you can make out a keratocyst in the middle. So this is this is the squamous cell carcinoma, and these images are from the scalp. There's the surface epithelium merging with apocrine epithelium, and in the bottom left you can see very nice decapitation secretion, and in the bottom right you can see the lymphocytic and plasma cell infiltrate, which is such a common feature of this tumor. And here we have photographs from the rest of the specimen. In the top left, this is typical deep component of MAC, although in this case it really looks more like the eccrine epitheliomatous variant, where there are some obvious foci of glandular or ductal differentiation, and then there are lots of narrow strands. And in the bottom left, again, just to emphasize the lack of pleomorphism in this tumor. And on the top right, you can see the tumors extending through skeletal muscle. And in the bottom right, in this field, the stroma is extremely sclerotic, really compressing the epithelial strands. And sometimes, if a tumor is composed mostly of this, you might mistake it for a more feiform basal cell carcinoma. And these 4 fields are just highlighting the extensive perineural and intraneural infiltration. This particular example was a very aggressive tumor. And Matthias did some immunohistochemistry, and I wanted really just to show you the EMA, which outlines the glands beautifully, and the CEA doing the same. And interestingly, diastase PAS highlighting epithelial mucin. And then we're going to come to the solid variant of MAC. And this is a case that Antonina Kalmakova shared with me. And I have to give her great credit for this diagnosis, because I was trying hard to make it into a trichoblastomatous lesion, perhaps trichoblastic carcinoma, but Antonina persevered and eventually persuaded me that I was wrong, and this was in fact a solid variant of MAC, so full marks to Antonina. The solid variant predominantly presents on the scalp, and it presents as round nodules of tumor cells, which do look a bit poroid, or very often they show clear cell change. And importantly, you will find the odd keratocyst if you look really hard, and you will see evidence of ductal differentiation, which you can highlight with EMA and CEA. And it's useful. BER-EP4 is a useful discriminant because it's negative in MAC. And here's the Antonina's tumor. There's no epidermis present, so we're looking at just a solid piece of tissue composed of dense collagenous fibrous tissue. There's some skeletal muscle caught up in all of this, and there's some subcutaneous fat. And here are some close-up photographs of that tumor. I hope you can see my arrow. It's in the very center of the field, the image in the top left-hand side, and right in the center is a focus of ductal differentiation, and the epithelium, and there's even better just there. And in the surrounding cells are showing clear cell change. And in the bottom left-hand field, you can see keratocysts. Now, it does take the eye of faith, but I rather thought in this top right-hand field, there was evidence of sebaceous differentiation. I think that's very much like a SIBO site there. So I thought this was solid MAC showing sebaceous differentiation. And in the bottom right, we can see P16 outlining the myoepithelial cells. The prognosis of microcystic adnexal carcinoma is rather variable. In the older literature, recurrences were reported as developing in up to 60% of cases. But I think nowadays, with careful Mohs surgery or plastic surgery with good frozen section control of margins, the recurrence rate is probably nearer the 15%. Now, there have been 3 reports of the literature of MAC involving lymph nodes and exceptionally systemic spread. Now, I did read these 3 papers, and I don't think I was totally convinced that they were examples of MAC. And a little while ago, I posed a question on McKee. Had anybody seen a case of microcystic adnexal carcinoma showing lymph node or systemic metastases? And nobody had. And we've a membership of around 18,000 people, so that's an awful lot of people who have not seen metastases in MAC. So I rather think it probably does not involve, is not associated with metastases. I wanted to, lastly on this slide, to make the point that if you remember the histology I've been showing you, the tumor is associated with a very dense fibrous stroma. And so I would strongly urge you not to treat primary tumor with radiotherapy, because if you do that and the tumor recurs, the stroma becomes even more sclerotic, and so you won't get a chance of trying surgery. So my approach would be to treat the patient with Mohs surgery and or plastic surgery, and radiotherapy would be a last resort. Now, the differential diagnosis of MAC includes a number of entities that you see on the left-hand side. I think the most important differential is really desmoplastic trichoepithelioma. Some people confuse squamoid eccrine ductal carcinoma with MAC, And so I'm going to show you a couple of examples of that. And on the right side, there's a nice example of Desmoplastic trichoepithelioma with, on the low power, you can see it's a rather small, and it's a superficial tumor. And most of these are superficial. But it does show a biphasic population of follicular keratocysts and narrow epithelial strands. And on high power, you can see how easy it might be to call that a MAC if you didn't know better. One of the interesting things about Desmoplastic trichoepithelioma is it has about a 40% recurrence rate. And so it's not surprising that people get very worried about it. And because it does look similar to MAC, people sometimes think when Desmoplastic trichoepithelioma, when it recurs, they think they've made a misdiagnosis. But that's not the case. It's just the tumor was inadequately excised in the first place. It tends to affect a younger age group than most cases of MAC, but clinically it can be very similar. And the important points are, one, it's confined to the dermis; two, there's no ductal differentiation, but sadly, perineural infiltration, which I always thought was a great clue to the diagnosis of MAC, that's no longer true. We've had to change our views on that. And this is a lovely example that Dr. Teppo Vail from Helsinki shared with me, and this is a Desmoplastic trichoepithelioma. It's a little bit deeper than most examples, but otherwise it's very typical, so I'm sure that's what this is. And a clue that's present, you see on low power, are all these foci of calcification, which are not something you generally see in a MAC. So I think they're a very helpful pointer. And there's a close-up view showing a keratocyst and narrow epithelial strands. And there's the middle of the tumor, much the same. But interestingly, now this is not so easy to see on this field, but where the arrow is, that's nerve tissue with tumor growing around it. And this next field, I think this is a bit easier. I think that this is more obviously a nerve, and there's perineural infiltration. And immunohistochemistry for cytokeratin, the nerve is right where the arrow is, and you can see a positivity with cytokeratin both above and compressing the edge of it. So that's a nice example of Desmoplastic trichoepithelioma with perineural infiltration. The other tumor that I mentioned that people sometimes get into problems with is squamous or squamoid eccrine ductal carcinoma, which affects the sun-damaged skin of the elderly and presents on the face and neck. And it's quite different from MAC, really, because it's a tumor of sun-damaged skin, and it has a significant metastasis rate of up to 13% in a series of 20 cases. So it's a different ballpark tumor. It's really more a high-grade lesion, and histologically it differs from MAC completely because it is biphasic, but basically you have squamous carcinoma on the top and a rather aggressive looking adenocarcinoma on the bottom. Some people call these tumors adenosquamous carcinoma. And the epithelium is typically pleomorphic and loads of mitoses, so it's very, very different from MAC on histology. And this is another case. This was shared with, again, by Dr. Teppo Vale, and on the left side you can see squamous carcinoma at the top. And whereas at the bottom, down at the bottom, and you can see that there's adenocarcinoma. So two different components: squamous carcinoma at the top, adenocarcinoma at the bottom. And I've turned this slide on its side just for ease of looking at. And this bit is the top. This is adenocarcinoma, or squamous cell carcinoma, and this is the deeper reaches showing adenocarcinoma. And here's another view showing the adenocarcinomatous component, and this is a diastase PAS showing lots and lots of mucin production. And then the other tumor that you might confuse it with, and I think it's a reasonable differential, is if you get a shaved biopsy of a trichoadenoma, then you might well have diagnostic difficulties. Trichoadenoma is very, very rare, and it presents as a solitary lesion. I'm not sure. I've seen maybe a dozen or so, but I can't remember what sites they were from, to be honest with you. But the important thing is that these show infundibular differentiation, and so they tend to have a granular cell layer. And if you did a shaved biopsy across the top of that, I can see that you might mistake it for a MAC. These tumors often show Merkel cells in the epithelial component. Now I'm going to change direction now and look at cutaneous adenoid cystic carcinoma. This is a different ballpark, really. It's probably rarer than MAC, but it's a more aggressive tumor. It really is a bad tumor when it presents in the skin, and it may the metastasis or the recurrence rate is high even with good surgical treatment. And I don't know, I put very rare metastases, and that's more a sense, but it certainly, it genuinely does have a metastatic potential. So you got to treat this one very carefully. And just to remind you, you always make sure when you look at an adenoid cystic carcinoma, make sure it's not coming from the underlying salivary gland, or that it isn't a metastasis from some systemic tumor. And this is an interesting case. Most of them occur on Caucasians, but this is an Egyptian patient that I got in the literature, and you can see it involved the upper lip and extending onto the cheek. And this patient presented with subpleural metastases as shown in this CT scan. So that just emphasizes the risk with this tumor. And this is a case that I saw where this was a recurrence. Now, adenoid cystic on a good day is instantly recognizable because the tumor shows this beautiful cribriform pattern as shown in the top right image. And this is from a case that Matthias Bobos shared with me. So cribriform nests are typical. You may also get little tubules and cords of cells. Unfortunately, some tumors have very large nodules, and you have to search hard to find the cribriform bits, and so the diagnosis can be challenging. In the middle, I'm showing a diastase PAS to show the tumor secretes mucin, and in the bottom there's a nice view showing beautiful cribriform adenoid cystic carcinoma. These tumors almost invariably show perineural infiltration, and myoepithelial cells are conspicuous in adenoid cystic, and you can demonstrate them with various markers like P63 and so on. Now, the interesting thing is that adenoid cystic carcinoma, for some reason, I don't really know why, but for some reason it's associated with basement membrane reduplication, so you can identify that with laminin and type 4 collagen immunohistochemistry, and I'll show you more of that in a moment. And MYB chromosomal abnormalities are found in 60% of cutaneous lesions, which is an interesting observation. So this is a case that Antonina Kalmakova shared with me, and you can see the on the left side of both pieces of tissue is the squamous epithelium, and deep is the underlying adenoid cystic carcinoma, shown a bit closer there. It is quite a difficult diagnosis at that magnification, but if we look at it a bit closer, one's beginning to see a nice cribriform pattern, and in this field one can see glandular spaces and rather solid cores of tumor. And here we have, this is textbook adenoid cystic carcinoma. It doesn't get better than this. Whoops. You can see that I hope you can see my arrow. The little ducts are lined by intensely thickened eosinophilic material, and these are basement membrane constituents. And as tumors age, you get more and more of this, and so if you look at the top right-hand edge of the tumor, you can see that there's no evidence of a lumen anymore. All one is seeing is this eosinophil material, and sometimes it's also present between the epithelial cells. And there's a close-up view there. And this is another case that Matthias Bobos shared with me, and you can see a nice cribriform growth pattern on the left, and just off-center is a nerve showing perineural and intraneural spread. And this is one of my cases, and you can see on the top left, I'm highlighting the eosinophilic lining of the ductal spaces, and this is I think this was laminin 5 showing basement membrane reduplication, and here we see mucin secretion and nerve involvement. And this is more of Matthias's case. It's a very nice demonstration of myoepithelial cells with P63. The CEA picks up the ducts, which in this case were rather more difficult to see. And in the bottom left, I think this is one of the most beautiful images I've ever seen in pathology. This is type 4 collagen, and wow, it's It's quite something else. I love showing that photograph, and adenoid cystic carcinoma often expresses CD117. And this is a case courtesy of Professor Qi Shunyang, and I put this one in because of the smooth muscle differentiation shown by SMA and P16. Now I'm going to change direction and talk a little bit about primary cutaneous apocrine cribriform carcinoma, sometimes known as solid-cribriform carcinoma. And it's very rare, and it doesn't really have anything terribly distinguishing, other than for some strange reason, and I have no idea why, 80%, or in fact more than 80%, have presented on the extremities. And histologically, it looks a bit like an apocrine carcinoma, except it doesn't have any nuclear pleomorphism. The nuclei are very uniform. It's not very mitotically active. It doesn't show necrosis. There's no evidence of lymphovascular or perineural infiltration. And in the skin, primary tumors in the skin don't really do anything, and so there's some debate as to whether they should be called carcinoma in the first place. And this case that Professor Qi Shunyang shared with me is really nice because it shows one other feature, and that is, for some reason, and I don't know why, these tumors often have dense lymphoid aggregates, sometimes with germinal centers, sort of bordering the tumor mass, and I don't think I've seen that in a sort of a genuine apocrine carcinoma. But the point I suppose one must make is that it's always wise to make sure that that there's no possibility that what you're looking at could be a metastasis. So before you come to this diagnosis, make sure you've spoken with the clinician and that they checked out there's no evidence of a more aggressive apocrine carcinoma somewhere else. And this is one that once you've seen one, you've seen them all, because they all look the same, and it's a very pretty, instantly recognizable growth pattern where you've got these large cystic spaces. You have bridging to give rise to a cribriform pattern. You get little papillae protruding into the lumen of the cystic spaces. There's more there. There's more there. And if you look very hard, you'll see decapitation secretion, which wasn't particularly easy to find in this one, but I think if we look along the edge of these glandular spaces, it certainly suggests decapitation secretion. And then I'm going to show you a few more of these, and you'll see why I say it's instantly recognizable. Immunohistochemistry. Well, everyone likes to do immunohistochemistry, and there's all sorts of things you can do, but I'm not sure really how that helps very much. The only thing that I think is particularly useful is GATA3, because it'll be negative, which means you can exclude a breast carcinoma metastasis. But it sustained with all sorts of keratins. It's BER-EP4 positive. Not surprisingly, it expresses EMA and CEA. So I don't really think immunohistochemistry has a large role to play other than GATA3. I suppose it's also worth noting that the cutaneous lesions are negative for the ETV6 NTRK3 fusion gene. Now look, you see, that looks exactly the same as the one that Professor Qishan Yang shared with me. One could just as easily be the other. And I want to emphasize the monomorphic population of cells. If this was an ordinary apocrine carcinoma, you'd have much larger cells. They'd be much more pleomorphic. And there, I think that's EMA. And here's another one. You see, again, now that you've seen two, this one, you don't even need to increase the magnification. It's just gorgeous. This one was very kindly shared by Mitchell Home, and he shared it on the Keynote.com platform, and I was absolutely stunned when I saw it, because I thought, wow, you just know what that is without any further magnification. But nevertheless, here are some higher power fields. And in this one, the apocrine decapitation secretion is more obvious. And then lastly, I want to talk about primary cutaneous secretory carcinoma. And this is another tumor where it's a diagnosis of exclusion, because secretory carcinoma may present both in the breast and in the salivary glands. So when you are looking at a case, you've always got to exclude metastasis before coming around to the notion that this is a primary cutaneous lesion. And the interesting thing is most of them occur in the axilla, and that makes it very difficult for me, because if the lesion is in the axilla, it's very hard to be sure you're not looking at a tumor arising in the axillary tail. But having said that, I've seen some examples presenting at sites very far from the breast and the axillae, so I think that there are genuine cutaneous lesions. And you make the diagnosis because of the vacuolated eosinophilic cytoplasm and the absence of severe cytological atypia. And that's really about the height of it. Immunohistochemistry, again, I'm not sure that it actually helps you very much. I put all this stuff in for those of you who are immunohistochemistry enthusiasts, but personally, I recognize this tumor on the basis of the H&E and following clinical information that excludes the possibility of a primary tumor elsewhere. Now this is the first case I saw, and it's a beautiful example shared with us by Dr. Viktor Grishakov from Moscow, and the patient presented with a nodule over the left hip. So it's definitely at a nice non-mammary site, and Viktor made sure that there was no evidence clinically of a tumor occurring elsewhere. So it's circumscribed nodule at the top, but it's not so circumscribed down below. It's infiltrating. But those are the typical features. It's absolutely gorgeous. You see, all of the lumina are full of eosinophilic granular material, and it's instantly recognizable, or it should be, particularly when you've seen a couple, because they all look the same. The interesting thing is the deep part of this tumor that Viktor showed, it looks a bit like a cribriform carcinoma, so maybe this is a mixture of two tumors, who knows. And there's a close-up view there. So, you know, once seen, I hope never forgotten. And that's that rather more cribriform looking bit. And there's immunohistochemistry on that tumor, but it doesn't really help me very, very much. But there's S100, GATA3 is positive. P63, you can't really make this out, unfortunately, but it confirms the presence of myoepithelial cells. And here's one that Muammar Arida very kindly shared with me, and it looks just the same as the other one, doesn't it? You know, they're all interchangeable. And then here's his immunohistochemistry, and not surprising, EMA and CEA are positive. And there's P63 outlining the myoepithelial cells. And here's an example of secretory carcinoma in the axilla, and I mentioned that that's a tricky one. You really have got to make sure it's not a breast tumor. But in the top left-hand field, in this region, you can see an apocrine gland, and I rather thought that just at the bottom there, we were looking at an in situ component. And if we accept that, then this all fits with a primary cutaneous secretory carcinoma. But you've got to be very careful about that diagnosis. And really, lastly, I just want to highlight, make sure that you're not missing a metastasis. And that's all I have to say, and I hope you've enjoyed my talk. This is myself and my wife Gracie on a nice hot sunny day, showing you where we live in France. So thank you very much for your attention, and I hope you've enjoyed the talk, and I hope I've taught you at least a little something. So thank you very much.